Good morning. I'm Dr. Elena Narne, working in the medical direction of Padova Hospital called Azienda Ospedaliera di Padova. Today, on behalf of my health director, I would like you to introduce to our hospital, giving you some numbers of our activity. Azienda Ospedaliera di Padova is a tertiary level teaching hospital of Veneto region. Its mission is supporting regional health system to pursue healthcare in local area, providing high complex and high technology healthcare at provincial, regional, national and international level, contributing to teaching medicine in the University of Padua, developing collaborative relationship with healthcare companies, territorial health trusts and other parties. I will give you some numbers of our hospital. We have 1,400 beds, more than 59,000 discharges every year, including ordinary and day hospital discharging, more than 44,000 of surgical acts, and more than 7 million of outpatient services. I will give you some other numbers about our activity. Regarding to organ transplant activity, in 2015, more than 280 organ transplants were performed, and the extra-regional extraction was more than 11%. All the specialties of activity are covered in our hospital. There are 15 specialties for surgical area, 16 for medical area, 15 for diagnostic service area, 10 for maternal and child area, 8 for ER and intensive care unit area, and 1 for rehabilitation area. Regarding to transplant activities, in this slide you can see all the numbers of organ transplant activity and bone marrow activity. And in the specific of liver transplant, 76 were performed in 2015. Regarding to the field of rare disease, last December, we received an important acknowledgement by the European Commission. In fact, Azienda Ospedaliera di Padova ranks in the first line for the number of groups that have been selected as part of specific European groups in this field of rare diseases, including the rare liver disease, where Azienda gets the best mark. Now, I'm introducing you Professor Paolo Angeli, head of the Unit of Hepatology of our Azienda.
Well, as Dr. Elena Narne told you, I'm Professor Paolo Angeli, the director of the Unit of Internal Medicine and Hepatology, that is also the referral center of the Veneto region for the liver disease. First of all, I want to thank the EASL Governing Board for giving us this great opportunity. Our unit belongs to two different entities, the University of Padova and the General Hospital that has been already described by Elena. The University of Padova is the second oldest in Europe, and it has had in its teaching committee Giovan Battista Morgagni, who was the first to describe cirrhosis in animals as well as in human beings. This is a great source of pride, a great source of honor for us, but it represents also a great source of responsibility. This is just one of the reasons why we are so motivated in performing research, I mean clinical as well as experimental research in hepatology. And today, during the presentation of the case, you will have the opportunity to appreciate some original, relevant contributes of young investigators in the management of advanced liver disease that came out from original researchers that were performed in our unit. But now it is time to go straight ahead to the case, and it is my pleasure to introduce you my colleagues who will present and or discuss the case. They are Dr. Salvatore Piano, Dr. Sara Montagnese, and Dr. Marco Di Pascoli. Thank you very much a lot for your attention.
Hello everyone, this is the case of a 57-year-old man with HCV infection. He was diagnosed as having cirrhosis in January 2015 after the appearance of ascites. He had F2 esophageal varices, diabetes, and he was on treatment with spironolactone 100 mg daily and propranolol 30 mg BID. He was admitted on May 2016 in our liver unit for the first time after the appearance of hepatic encephalopathy, ascites, and dysuria. Lab tests at admission showed mild anemia and mild hyponatremia, increased level of C-reactive protein and liver enzyme test. In addition, he had an impaired liver function and increased levels of venous ammonia. We did a workup for infection, and chest X-ray and paracentesis did not show signs of infection. Conversely, urine analysis showed signs of a urinary tract infection. And at this time, we also performed urine, blood, and ascites culture.
As you know, according to the most recent set of joint EASL Guidelines, hepatic encephalopathy should be qualified by type. Type A if it is associated with acute liver failure, type B if it's due almost exclusively to portosystemic shunting, and type C if it is related to cirrhosis. It should also be described by its grade of severity, its time course, and it should be defined whether it is precipitated or spontaneous in the case of a precipitant not being identified. So in this particular instance, this gentleman would be qualified as having type C, overt grade 2 hepatic encephalopathy. In terms of its time course, it's episodic because there is no previous history, and it is most likely precipitated by a urinary tract infection. This gentleman was treated with high-dose ciprofloxacin, 500 milligrams BID. His diuretic regime was increased to 200 milligrams spironolactone and furosemide 25 milligrams BID, and he was also administered lactulose.
So, after an initial improvement, on day 5, the patient developed abdominal pain, fever, and oliguria, and hepatic encephalopathy, a new episode. At this time, we repeated the lab test. They showed leukocytosis, an impairment of renal function. Indeed, this patient had an acute kidney injury stage 2. There was an increase in C-reactive protein and a further worsening of liver function. We repeated the paracentesis that showed signs of a spontaneous bacterial peritonitis, and at this time the patient had a very high MELD of 31. According to the EASL Cliff Consortium, organ failure has been defined according to a modified Cliff SOFA score. And as you can see here in light blue, I reported the organ failure, and our patients had coagulation failure, but also hepatic encephalopathy and a mild impairment of renal function with a creatinine between 1.5 mg DL and 2 mg DL. Thus, according to the canonic study definition of ACLF, this is a patient with ACLF grade 1 type B, and it means that he has a high short-term mortality. So what we did in our patients with an ACLF that was probably precipitated by a bacterial infection, namely SBP, was to withdraw diuretic due to the acute kidney injury and to administer albumin as provided for the prevention of hepatorenal syndrome in patients with SBP. However, we did a little deviation from the standard protocol because the second dose of albumin was administered on day 2 instead than day 3, because we had to do as soon as possible the differential diagnosis of acute kidney injury in this patient. As antibiotic treatment, we administered meropenem 1 gram BID and daptomycin at the dose of 6 mg per kilogram per day. And the reason why we administered such a broad spectrum antibiotic regimen was related to the high prevalence of multidrug-resistant bacteria in our center. Indeed, we have shown in a randomized controlled trial that meropenem plus daptomycin is significantly more effective than third-generation cephalosporin in the treatment of hospital-acquired SBP. However, it is important to highlight that such an antibiotic regimen may be not the most appropriate in other centers where the prevalence of multidrug-resistant bacteria may be lower than in our center. However, it is very important to know very well the local epidemiology in order to administer the most appropriate treatment, because an effective initial antibiotic treatment is associated with a significantly better survival than a non-effective initial antibiotic treatment, regardless of the final resolution of infection. So on day 7, we had good news and bad news. The good news was the reduction of PMN on acidic fluid and the reduction of C-reactive protein. Thus, it means that our antibiotic treatment is effective. The bad news was the further increase in serum creatinine despite the diuretic withdrawal and the administration of plasma volume expansion with albumin. So what we did was to perform a differential diagnosis of ACI, in particular to check for the criteria of hepatorenal syndrome. A urinalysis and 24-hour urinary protein excretion were normal. And we also tried to look for urinary neutrophil gelatinase-associated lipocalin, that is a promised biomarker of tubular damage. It was quite increased, not so high, but we also had to know that it may be increased also due to the recent urinary tract infection that may increase NGAL without signs of tubular damage. At this time, our patients had an ACLF grade 2 because of coagulation failure and renal failure. And renal failure had the phenotype of hepatorenal syndrome. What we did was to administer albumin at a dose of 40 grams per day and terlipressin as continuous intravenous infusion starting from 2 milligrams a day. We also reduced the doses of antibiotics according to the estimated glomerular filtration rate. But the reason why we administered terlipressin as continuous intravenous infusion was related to the fact that we were able to show in a randomized controlled trial that it is effective at a lower dose than intravenous boluses in the treatment of HRS. Most important, it has been associated with a significantly lower incidence of side effects in these patients, and the continuous infusion is the standard protocol in our center. So during the follow-up, the patients improved, and after 7 days we got a resolution of SBP. We withdrew antibiotics and we started secondary prophylaxis with norfloxacin. We needed to increase the doses of terlipressin up to 6 milligrams every 24 hours, but in the end we get a resolution of HRS and we were able to withdraw terlipressin after 12 days. And then, meanwhile, we assessed the transplant eligibility of our patient. The patient was considered eligible for liver transplantation and listed on LT waiting list, and subsequently discharged.
After discharge, the patient was followed up on the care management program, which is a new model of specialized care for outpatients with decompensated cirrhosis, which has been recently set up in our clinic. The one-day checkup is carried out by a consultant hepatologist who examines the patient and coordinates integrated activities, including lab tests, liver ultrasound, endoscopy, and other specialist referrals. And, when indicated, also the one-day hospital admission. Then the results are shared with the primary care physician. To this approach, we observe a significant improvement in the 1-year survival probability compared to the standard outpatient care. In addition, the rate of readmissions within 30 days was significantly decreased in the care management program, resulting in a decrease of the overall cost for the management of these patients.
Indeed, the patient was followed up within our care management program. He required 2 further paracentesis, but was not readmitted to the hospital. He was subsequently transplanted in August 2016, and he has just completed the treatment of HCV infection with direct-acting antivirals. We want to thank you very much for your attention and for watching this clinical case, and we really hope you enjoyed it.